This session is going to discuss the Uganda-Case Western Reserve Research Collaboration, 20 years in the making. And we've got a real treat because we have two of our most senior and respected infectious disease investigators here on the platform at the same time. I'm not sure I've seen you guys in town at the same time in a long time, because this Uganda collaboration is a genuine collaboration, and they do spend a lot of time in Kampala and on site with both their clinical and their research studies. I'm going to introduce them both to you and then turn the program over to Bob Salata. Many of you may know Bob Salata. He is a professor of medicine, international health, epidemiology, and biostatistics, and is chief of the division and clinical program director for the Division of Infectious Disease in our Department of Medicine. He's also vice chair for international affairs in the Department of Medicine at university hospitals. He is the medical director of the Travelers Clinic and medical director of infection control and prevention at UH, and I'm very grateful that he's serving as the medical school representative to the Influenza and Pandemic Task Force for the university. Bob was graduated from Notre Dame with his bachelor's degree and is himself an alum of Case Western Reserve University School of Medicine. He did his fellowship at University Hospitals of Virginia. He returned to Cleveland as an instructor and chief resident in medicine, and rose through the ranks to become a professor and division chief in 1996. He has published more than 110 chapters and 75 papers and 3 textbooks in this area. So he has a tremendous background in infectious disease and a tremendous background in medical education. His confrere here is Willem Henry Boom, whom I learned from your bio has dual citizenship in the United States and the Netherlands. He graduated from Amherst College. He went on to earn an MD degree from the University of Rochester and did his residency at George Washington University Medical Center, completed a clinical and research fellowship in infectious disease and immunology at Massachusetts General and Brigham and Women's Hospital, and he joined Case Western Reserve in 1988. He has also risen through the ranks and now directs the TBRU, the Tuberculosis Research Unit at Case Western Reserve, which has been the largest single grant to the university over the last few years. Dr. Boom is an accomplished researcher in the immunology of tuberculosis and has a great deal, I think, to teach us about how this bacterium survives and reactivates in human beings. So this should be a really exciting presentation here from two of our top experts, and I'm going to turn the program over to Bob to kick it off.
First of all, do you really need the microphone? Am I projecting loud enough? I think that would be better, thank you. It's often hard to hear the words that we've become graybeards here, or most senior, I think, is the term that Pam used. But we really have been committed to this venture for a long time, and truly this is the 20th year anniversary of this collaboration. And I'd like to tell you a little bit about this at the outset and describe some. I'm going to really focus on our HIV/AIDS research that I've been involved with in the second part of my talk, and then talk about a newer development, which is very exciting, the development of an international clinical trials unit, which is part of a national network that is in the United States, and this is now based as a sister site of ours in Uganda. We'll talk about that as well. This all started 20 years ago at a time when Case Western was then known for its global emphasis in its research initiatives. And a new regime came into place in Uganda in 1986 And they soon recognized that they had a major problem with what they called slim disease in Africa. And even at that time, we did not know the true etiology of what was happening. They invited several Western institutions to come and help them sort through this and to assist them in dealing with this both clinically and begin to think about ways to prevent this from happening. And it really was Fred Robbins, then a former dean here, Nobel laureate, that many of you know.
They're recording.
They're recording, no problem. We're stuck. Do you want me to start all over? And Fred led an entourage over to Uganda, and this really initiated this entire collaboration. And it's been fully funded over this period of 20 years, and it's been highly successful, and I'll give you some highlights of that in a few minutes. So it did start in 1987 through this invitation. There was a memorandum of understanding reached between the Ministry of Health there in Uganda and Case Western, and it really led to this international collaboration. At the outset, the focus was on HIV, its natural history, of course tuberculosis, which was another prominent consideration for my predecessor, Jerry Elner, who led the TBRU before Henry assumed control of this some years ago. But also malignancy, even at its early stages there, plus some work in anthropology. And as a foundation of what we do there, we set forth the process of making sure that training was an integral part of whatever we did. And this initiative is now led by Chris Whalen in our Department of Biostatistics and Epidemiology, and he's done a wonderful job, and I'll give you some data on that in a second. Now that was then, so back in '87 or so, and this is a world map from UNAIDS that shows how this has literally exploded. That is the numbers of cases of people estimated to be living with HIV/AIDS in this day and age, and we're up here. It's close to 40 million. This is a great underestimate because many rural areas, people do not have the capacity to establish a diagnosis or report, and many countries don't do this reliably either. Just bring your attention to this line, which parallels this epidemic, that is the number of children left behind as orphans, particularly in sub-Saharan Africa now. So we are there now, and this problem is not going away, particularly in sub-Saharan Africa. And if you look at the worldwide occurrence of HIV/AIDS with people living with such, you could see going up to the reddish areas, these are the areas of the world which harbor the most infection. And particularly now in southern Africa, where the prevalence rates may be as high as 40 to 50% in some areas. It's just staggering. There are 3 other areas of the world where HIV is really exploding. That includes India, China, and Russia. And there are certain things that feed into the epidemics there, but given the population densities in these countries, we can expect rates of infection in those areas, unless we bring it under control, that perhaps parallel those that we're seeing in Africa. And this is where we work in Uganda. For those of you that remember, it borders Tanzania, Rwanda, Congo, and Kenya, and Sudan to the north. We arrive here in Entebbe. Many people know about what happened at the airport there many, many years ago. And we work primarily in Kampala. We have a long-standing relationship with Makerere University, which is the second oldest school of medicine in all the continent of Africa. And we work at Malago Hospital, which is their major teaching affiliate. Across town, about 8 kilometers, is another place where we have actually set up the International Clinical Trials Unit called the Joint Clinical Research Center. I'll come back to this later. But these are pretty adjacent, and I have work going on in both areas. Henry does too, but primarily is focused here at Malago Hospital, and he'll speak more to that later. The themes and the foundation for the collaboration are shown in this slide. HIV transmission, natural history, the relationship with TB, and HIV-related malignancies. Now, this work right now is headed up by Scott REMIC, who's a professor in the Department of Medicine in Hematology and Oncology. Training, as I mentioned, is a major part of how we operate. in terms of training the Ugandans themselves, who have gone back to become the leadership there as part of this collaboration. Technical training, tech transfer has always been a part of it, and I will say, in terms of the work that I do, Henry will speak to his own, that the laboratories that we utilize there are state-of-the-art, just like anything we have in the US. We also have done a lot to develop things there in terms of data management, laboratory capacity, et cetera. Some of the highlights of this collaboration are shown here. There's currently, or in the past, more than 20 completed or ongoing studies. There's over 150 peer-reviewed publications emanating from this, with 400 scientific abstracts. 90 Ugandans have been trained through this process. And the research design has included clinical trials, observational studies, and more recently, really elegant translational studies correlating clinical findings with back to the bench and vice versa. Many people that are prominently involved, I'd like to just, for my purposes, single out a few. Roy Magerwa has been the principal investigator there. He's a professor at their medical school who has really stimulated and advanced the collaboration through the years. Peter Mujeni, who's the director of the Joint Clinical Research Center, worked closely with him there, as does Henry. And Harriet Mayanja, who is currently one of the people trained here, who's the current chair of medicine at the Malago Hospital, and others. And from the case side, there have been many individuals, I can't list them all, but again, keeping Fred Robbins in mind, Jerry Elner, who really stimulated this at the outset, and many, many individuals still involved very prominently in the work. So let's turn my talk now to some of the HIV/AIDS related research. This is taken from St. Elizabeth's Park, which is in the southwest of Uganda. It's a beautiful place to go. I strongly encourage anyone to go there. Among other things, Uganda has been called the Pearl of Africa. This was so named by Churchill. It's very fertile because of Lake Victoria and the Nile River, which is the largest river in the world that runs south to north, really enriches the entire country. So it's a beautiful place to go and see, but also, and most importantly, the people are just wonderful and they're very welcoming, and they've been really a testament to this collaboration, why it's been so successful. There are several ongoing studies at this moment that relate to HIV/AIDS. One is one that I'm prominently involved with. We've developed a cohort of women, not only here in Uganda, but also in Zimbabwe, where they're infected with different types, sub-infections of HIV. And this gives us some interesting comparisons to make later in our data analysis. I'll show you some of that later. And we're looking at the natural history. We're introducing medications to treat this. We're looking at outcomes and looking at the viral end of things as well. There's work going on with human papillomavirus. That's been in the news recently with regard to a preventative vaccine, the first one to prevent a cancer. This is associated with cervical cancer and anal cancer in some circumstances. We have separate funding to look at clinical outcomes and resistance as these drugs are now finally, still not enough, it's still not adequate, but finally being introduced throughout much of Africa now. Politics aside, one thing that has stimulated this is the PEPFAR program, the President's Emergency Plan for AIDS to Africa, and this has really been one of the vehicles that has enabled this to happen. Scott REMIC is looking at simpler, tolerable forms of chemotherapy by mouth to treat lymphoma, which is a major AIDS-associated malignancy. We're looking at common bacterial infections. Henry will probably talk about this later, and I don't want to steal his thunder, where they're looking at a strategy to give antiretrovirals when someone has acute tuberculosis. Why is that being done, et cetera, he'll explain. Around the world, one of the major things that has been accomplished in HIV prevention has been to give these drugs to mothers who are HIV infected and prevent the occurrence of infection in the infants. And that's been a major, major success story. There, they use a drug called Nevirapine. Nevirapine is in the class of the so-called non-nucleoside reverse transcriptase inhibitors. It's got a very long half-life, and importantly, it lasts for a long time once it's given, and it's cheap. For treatment of mother and infants, it's probably about $4 US altogether. And it's decreased the occurrence of transmission by over 50%. We'll come back to this issue because there are some problems that have come up here related to the fact that these same mothers who have benefited from this develop resistance to this drug after a single dose. Will this drug be helpful later in pregnancy? Will it also, when they're ready to be treated with broader treatment, can it be included in the combination cocktails? One of the areas I've been working on since about 1996 in Africa is looking at another important public health issue. There had been several studies that had suggested that hormonal contraception, used by women of course, for population control, really did increase the risk for HIV. This was an unanswered question, and we looked at that map a few minutes ago. HIV is becoming a disease of women around the world. In sub-Saharan Africa, about 58% of all infected people are now women, of childbearing age primarily, and they are using hormonal contraception to this degree. So we set forth to do a study through the NIH based not only in Uganda, but Zimbabwe and Thailand, where we had to enroll over 6,000 women to answer this question. You can't ask women to be randomized to receive one form of contraception or another. So we allowed them to use whatever they wanted to, but the analysis did provide for switch in methods, or pregnancy for that matter. Our primary objective here was to see whether or not either oral contraceptive pills or injections, and this is really the way this is given primarily outside the US, led to an increased occurrence of HIV. Along the way, we did many other things. We've kept specimen repositories, a lot of data on clinical outcomes, and we tested for sexually transmitted infections, because in these countries, these are so intimately linked. The bottom line is they were screened, they had to be HIV negative to be enrolled, and then we followed them every 3 months. There were many benefits to these women. For instance, the introduction of pap smears regularly in countries like Uganda. They had never been done before to this degree. So this study really has been, I think, provided leverage for the introduction of this type of approach. Thailand, as you saw, was part of it initially, but that's been an amazing story. They have really been able, though they have many people that are currently still HIV infected, their new cases have greatly diminished, in part because of mandatory condom use, particularly in commercial sex workers in that country. And in our studies, they contributed only 4 cases of HIV seroconversion. So we really focused our analysis, which will be published next month in AIDS, the journal AIDS, in our African populations. You could see that they were pretty well divided between those receiving pills, injections of hormone, or non-hormonal means, like condom use primarily, or tubal ligation as their means for sterilization. So these women were seen on an average of almost 24 months and followed. Now this is an amazing figure, and Henry's studies show similar numbers, but the retention rate was incredible. These people in Uganda, especially, once they join a study, they are so loyal, it's incredible. So we had an overall retention rate of 92%. And that's been one of the things about this collaboration, and these people in these countries, they are so willing to participate, and they continue to be willing participants. And if you really look at the HIV incidence rates over time, they're not different over time, which is also pretty amazing in both countries. You would think over 2 to 3 years, with constant counseling of these women, every time they come in about risk reduction for HIV and other things, that you'd see these rates go down, but they haven't. And the problem with this, in part, is that many studies that are being designed are based on prevalence rates. That is, whoever has had it before, now, et cetera. They're not really looking at incidence rates. This relates to studies designed to look at the effectiveness of a vaccine, or another really interesting and exciting area, topical agents given intravaginally, so-called topical microbicides, to prevent HIV via sexual transmission in the first place. But we found this to be a pretty remarkable finding. And if you look at the African sites only in terms of our primary endpoint, no matter what group they were in, we did not see that hormonal contraception increased the risk of HIV acquisition. And that's a really important issue. Imagine that it did. This would change the landscape in terms of the public health issues here and the research agenda, but it did not. As these women were enrolled and followed, and once they seroconverted, those women that did, we were able to get additional funding now through 2010 to follow these HIV-infected women where we know pretty much when their time of seroconversion occurred. And many diseases, having a cohort to follow longitudinally has taught us a great deal about the natural disease course with HIV and a number of other things. With HIV specifically, knowing when they seroconverted is helpful because many of the other cohorts are dominated by people with mixed infection early on or late. So the generalizations may not be as secure, and also they're male dominated. So this is the first one that looks at women only. When we looked at some other things, we did find that the incidence rate was higher in Zimbabwe than Uganda, but that's, I just told you about the epidemic. That's not so surprising, but this was almost 5 women per 100 women years of follow-up. If they lived with a partner, it was protective. That suggests that being in a monogamous relationship was protected. Earlier age groups had a higher rate. These women are probably more sexually active and exposed. And some other things like risks in the participant or partner. I'm not going to go into those in any great detail. If you look at that occurrence of HIV worldwide, you can really look at sexually transmitted infections in the same way. Henry will show you a map that suggests TB is occurring in the same areas. So we had a chance to look at sexually transmitted infections in the same group of women. And again, we found prevalence rates of 17% in Uganda at the time they were initially screened, and 40% in those Zimbabwean women. That's why their incidence rates were much higher. And we looked at HIV and sexually transmitted infections over these countries. There's some interesting things. Here's Uganda, Zimbabwe, Thailand, I'm showing you again. HIV, chlamydia, gonorrhea, trichomoniasis, bacterial vaginosis. Some argue whether this is a sexually transmitted disease or not, and syphilis. In general, these rates for almost all of these infections were much higher in the Africans as opposed to the Thai women, except for chlamydia, which was by distinction higher there. And some have said that this sexually transmitted infection is seen more in in middle income countries as opposed to the resource constrained areas where in Africa where we studied this. But all of them occurred very significantly, and for the most part were more statistically significant in African women. Then we looked at HIV, which I just showed you. We first evaluated by their category as to whether they received contraception or not. But many of these incident sexually transmitted infections, and we always use the term STDs beget other STDs. Here's clear confirmation of that. If you had a new infection with chlamydia, gonorrhea, trich, or bacterial vaginosis, the rates, the odds of developing HIV were anywhere from 2 to 10-fold greater, particularly for gonorrhea here. And then we looked at gonorrhea and chlamydia, and there were some demographic features that suggested which women were at highest risk: lower age of starting intercourse, fewer years in school, if they engaged in any commercial sex, alcohol use during sex. One of our other young investigators here, Ajay Sethi, is looking at this whole issue of alcohol use and HIV risk in Uganda as well. So hopefully we'll get more and more folks to join the bandwagon here. And for trich, there were other situations that predicted whether a new infection with trichomoniasis occurred or not. Now, I talked mainly up to this point in time about the women that were negative initially enrolled and the endpoints there. I'm going to spend a little time talking about those women that became positive added to our analysis here. But you can see that there are a number of studies primarily orchestrated through Case Western Reserve University that are still ongoing. And just a few little bits of information. Here are the overall numbers as it stands now. We are still enrolling into this HIV incident cohort. So we're up to 275 women of 315 that have seroconverted. That's about almost a 90% enrollment rate. At this point in time, about 15% of these women are on treatment for their HIV. But remember, this started as acute infection. Over time, we expect more and more of these women to require treatment. But this gives us the opportunity, in women particularly, to study their outcomes related to the introduction of such therapy. One of the things that happens with HIV when you're first infected way back here is that the viral load is very, very high initially. And that's, from a public health standpoint, one of the highest risk situations for transmitting this to others. Then this comes down to a level, that level dependent on whether it's high or low predicts how rapidly they go on to develop AIDS. And we've done the same analysis here in our cohort of both Ugandan and Zimbabwean women, and they're no different between the countries, looking at what is called a viral set point, okay? That's predictive, and I'm going to show you a little more information in a second. But the unique thing about this cohort is we collected specimens from the lower reproductive tract as well. And this is the first time where someone could look at a viral set point from that compartment, which from a transmission point of view is even more important. So we're following this kind of information over time. Eric Artz, who's also in our division, is one of our PhD research scientists, is really interested in the virus end of things. And I told you that from Uganda up here where we work, and in southern Africa where the Zimbabwean cohort of women live, and we go to work there, that they have different types of HIV infection. This is really an issue in terms of vaccine development. Around the world now, the subtype that is most prominent and present in those southern African areas is subtype C. In the United States, we are primarily dealing with subtype B, whereas in Uganda, it's A and D. The point is that almost all the studies done of the drugs that we use and the history of natural history of HIV have been done in industrialized countries with subtype B infections. We need to know whether this is going to be the same in other areas of the world to inform our care of those patients, the approach to vaccine development, and a number of other issues. The other thing that Eric does is he can actually take viruses isolated from these individuals and do a study which delineates their so-called fitness. This is the capacity of this virus to replicate. Some have tried to correlate this with the aggressiveness or virulence of the virus, but there's not a strict correlation in that regard. And up to this point in time, fitness of virus has not necessarily correlated with clinical outcome. And in Eric's studies, subtype C, which is here, is always less fit, doesn't replicate as much as subtypes A, D, and B. Okay, that's shown here. So here's subtype C. If we take this out, here's A's, D's. B's and D's seem to be the most aggressive, whereas A's are kind of intermediate and C's are the least. And given what I just told you, that C is the most predominant subtype around the world and its rate of occurrence is increasing, this is of possible interest because if it's less fit, doesn't cause clinical disease as much, it may be that these people remain asymptomatic but can serve as a reservoir for transmission to others. And we have a little bit of data from our cohort that's tantalizing. If you look at the rate of CD4 decline in the Ugandan women shown in blue versus the Zimbabwean women in red, there are differences. The rate of decline of CD4 counts is more in the women from Uganda versus Zimbabwe. Again, we're dealing with A and D subtypes here and C here. And if you really plot this out based on this kind of slope, then we would predict a mean of 8 years until women in Uganda progress to AIDS, either clinically or by way of their T-cell counts at or less than 200, whereas this appears to be 20 years in Zimbabwe if you look at the rates of these slopes. This is the first time that anyone has shown this We have been told after presenting this in Toronto this past August that some other groups are seeing the same phenomena. This is very interesting, both in terms of the epidemiology and pathogenesis. The last area I want to talk about briefly is the International Clinical Trials Unit that we have established in Uganda. This is all part of the AIDS Clinical Trials Group, which is a NIH-sponsored network currently of 33 domestic sites to study therapeutics in HIV. All the recommendations that really have come about how we care for HIV-infected individuals in the United States really have been propelled by many of the studies done here. And as the NIH and other government leadership, national leaders in science have recognized that we can't operate in a vacuum. Case Western never has. They have provided more and more funding to start looking at these problems in a global manner. So I mentioned to you before the Joint Clinical Research Center, which is based in Kampala. It was started in '91. It is a research and now clinical care associated institution. It was called joint because it was a joint venture between the Ministry of Health and Ministry of Defense, who was one and the same person back then. But also it works very closely in collaboration with McCary University that I've introduced to you before. Incredibly so. Whereas here, on an annual basis at university hospitals, we see about 1,000 HIV-infected individuals in our outpatient area each year. They see 10,000. The JCRC also has developed a plan to develop centers of excellence through the entire country, mainly to use that PEPFAR funding to provide antiretrovirals. There'll be up to 100,000 individuals who will be receiving antiretrovirals through that program. These centers of excellence will have clinicians, knowledgeable clinicians on site, as well as diagnostic capability to look at outcomes. It's a pleasant place. This is Eric Artz, by the way, who I've mentioned already, and some of his colleagues from the past. This is, again, about 8 kilometers. In this area right now, there's a brand new research pharmacy that really came about because of this collaboration. And it's just incredible how they're expanding. The laboratories on site are also very sophisticated. Their laboratories, in order to become an ICTU, International Clinical Trials Unit, recently had to undergo very stringent testing and evaluation according to US standards, so that they are now approved, CAP approved, which is the College of American Pathologists. It's really the second laboratory in the country that has this designation. And I'd like to tell you lastly about the first protocol that we're going to put through this ICTU. And then finish up. Remember, before I talked about Nevirapine, and it has become in Uganda and many other African countries as well as the Far East, the standard of care to give to mothers that are HIV infected to prevent infection in those infants. But it's come at a cost because about 70% in some studies and even more of these women, their virus will develop resistance to this drug when given as a single dose. And I'll also tell you why we think that's happening in a second. But this drug is part of their established or combination therapy as well. They don't use some of the more advanced drugs like protease inhibitors there because of cost, storage issues, et cetera. So not only is Nevirapine being used for mothers a lot, but it's also being used for rolling out the therapy for established infection in these countries as well. Here's one study where they looked at the levels of Nevirapine over time in women who had received a single dose. And this represents those percent of women after a single dose that had detectable Nevirapine levels over time. And you can see that even out to 3 weeks, almost 16% of these women had detectable levels. And that means for a long period of time, weeks in fact, the virus in these women was seeing sub-inhibitory concentrations of a single drug. This is the very setting where we see resistance develop. And we know also that, unfortunately, with this class of drugs, Nevirapine, it takes a single step mutation in the virus for resistance to occur, and then it's across the entire class. So obviously the concern is that as this is being increasingly used in the settings that I described, we're going to see more and more resistance, and this drug will become obsolete very quickly in these countries. It does decrease, that is, your ability to detect resistance over time, as shown in this study, but often this becomes such that it's in such small numbers of the virus that you're testing in that person that it's archived, and it probably is still there. However, in 2 smaller studies from Botswana and Thailand now, where Nevirapine was given to women who had experienced Nevirapine in a single dose previously, for now established infection, about 80% of them did quite well. That's about the same rate that you see with any other study in the United States. This remains an unanswered question, and it's important that we investigate that. So women from our site, as well as 9 other African sites, will be involved. There'll be a total of about 740 women enrolled in this to be randomized when they reach their T-cell levels that are where it's indicated that they receive combination therapy to either Nevirapine-containing regimen or one with a protease inhibitor. And they're also receiving a protease inhibitor they don't have a lot of experience with, but they want this. They really are hungry to use this drug as well. So I think it's a benefit to them. And the last 2 slides here show a number of ideas that we have had with our colleagues locally, and I'm not going to go through these in any great detail, which will serve the basis for further research in the future. We're always trying to think ahead. The one thing I have to emphasize for our work, that of Henry's, of course, and his colleagues, is that we have to do research that's scientifically relevant to these countries. We can't take our studies from the US to them. We need to think about things that are meaningful to them. And many of these ideas reflect that have just not been done before. And I myself personally have many collaborators to thank at multiple institutions and certainly at the NIH. Joanne Lewoto, who is our program officer, died in the last year of malignant melanoma. We'll miss her deeply, but I thank every one of these people for their time and effort, and especially the volunteers for our study, because they could not go on, and you've seen how loyal they have been to us. Thank you. The overall population of Zimbabwean women by CD4 count, which is one of the immune markers for disease progression, are less rapidly progressing.
And you had the viral difference. Do you think that's an explanation for the slow progressors in the MAC study?
I don't think that there are such distinguishing subtype infections in that study that you're referring to, the MAX cohort. That's what you're referring to, is that right? Really, that's a study that's been published by John Mellors from Pittsburgh, where they looked at that viral set point. And if it was higher, you would progress faster to AIDS. And if it was lower, there'd be a much longer time. What I haven't shown you in the analysis that I just did, that was only CD4 count. We don't have enough or sufficient viral loads in these women to look at that issue as well. We will be doing that, yes. Any other questions? Yes.
This is not directly about your research, but do you have any other groups you're working with to look at the cultural issues? Because all you're doing is suppressing the disease right now.
Yeah.
You still have all the issues of how it's transmitted.
Sure. I think that's an important question, very important question. And a couple things I would say in response to that. One is that Uganda has been one of the African countries which has been touted for their decreased rates of infection throughout the country. And that's mainly been through educational efforts and cultural change. In addition, we know the utility of having culturally based research as part of what we do, behavioral research, and we have colleagues in the Department of Anthropology that work closely with us, Janet McGrath, for instance. So that's being incorporated into some, but not all of our research. But you're absolutely right. You have to look at this in a broader way than just giving drugs, seeing a change in that regard, because there are many other things going on. You have a comment to that?
No,
Okay.
just, you didn't mention it, but I saw the anthropologist up here this morning.
Yeah, thank you very much, because that's important as well. Okay, yes, sir.
Will the Ugandans ever be
In terms of their care and research, well, that's what we're all striving for, because what's our point of being there? We're not there to do imperialistic research. We're there to work with them. I don't see our pulling out. We've been there for 20 years, and I think we want to work right with them. If they take a higher degree of leadership here, that's fine with us. And in fact, that's one of the things that we strongly promote in the end. And as I told you, we've trained a number of Ugandans, 90 or more, and many of them now serve in leadership roles in terms of this whole process and in their country, independent of the case research collaboration with us. So I think that's an important thing to keep in mind.